All right, well, first, let me say welcome and thank you to the folks that have joined. I'm sure more will join as we get started, but we have so much to talk about that let's just get right into it. This is the very first Analytics in Palliative Care Journal Club. Thank you to the organizers / panelists, Dr. Kelley, Dr. Twaddle, Dr. Lustbader, Dr. Bull. I'm Leonard D'Avolio and Dr. Caitlin Brennan. So this, let's do logistics first and then just get right into it. Let's see here. Okay. Number one, we're going to do our best to start on time. Number two, we are recording, and whatever we record will be posted to the Cyft website. Number three, everyone has a button at the bottom of the screen, which is Q&A. So please enter questions. Because of the number of folks, we won't be able to turn on everyone's microphone. We will do our best to try to weave your questions into what we're doing. And we'll even take those questions afterward and try to process them and figure out, how can we keep this community alive by continuing to address those questions. And finally, we will be sending a 5-question survey to follow. We are a data-driven group, and it would be inappropriate if we didn't attempt to collect some data to figure out how to do an even better job moving forward. Why this study? Well, a little bit why this journal club. My background is in data science, and I've been reading up on the literature related to data science and palliative care, both from the clinical side and from the data science side. And I found myself in conversations with Dana and Martha about the enormous potential for the two sides to come together, but also the challenges in the fact that they see the issues a bit differently. They use slightly different metrics. They use a slightly different language. And in the course of our conversations, we said, I wish there was a better way to bring everyone together to form that common language and understand the issues that matter most. And then I read the paper by Dr. Kelley that we are focused on, and I said to Martha and to Dana, this is the study we have to start with. Let's do it as a journal club. We called Dr. Kelley, we called Dr. Bull, Caitlin said, I'm in, and here you have it, the very first Analytics in Palliative Care Journal Club. And this study of all studies is an incredibly interesting bridge between the two worlds. And I'll quote the author, who it's just so great. I'm going to keep saying the author, Amy. It's an honor to have you here, but I will maintain that bit of formal decorum in referring to the authors. And it, of course, is Dr. Amy Kelley and also Evan Bollens-Lund. And I think they said it best. Central to the success of community-based palliative care programs is the ability to identify those with the greatest need. And they also point out the challenges that the field has had in doing so to date. And I think this is incredibly timely in light of the fact that there are a number of new value-based contracts being introduced, whether it's PCF-SIP or direct contracting via the high needs population, or eventually VBID, where the very design of these programs starts with prospectively finding the right people. And so what a great study and time to take on those issues. Now, the data science community has been attempting to contribute to the advance of palliative care and the specific issue of finding the right people. But in study after study, what they're really doing is predicting mortality. And I'm not going to go much further except to say that it probably doesn't suffice. Certainly contributes, but probably doesn't suffice. And so how can we take the capabilities of data science and the clinical needs of palliative care, bring people together and discuss the issues? And in every data science study and every study attempting to find the right people, there are 3 things that matter. It's the data, it's the algorithm, it's the measurement. And if we, as a combined community, can use a common language and have a shared understanding of, is the data used in this study appropriate for the problem I'm trying to solve? Are these algorithms accurate enough? What is the difference between these algorithms and my clinical environment? And then finally, what are the metrics that matter? If we can have a shared language and shared understanding around these 3 issues, and interpret studies accordingly, then I think we have a chance to progress the field more effectively than maybe we have been as these 2 sort of silos that haven't been meeting in the middle. So the great thing about this study is it really gives us very meaty topics in all 3. the authors combine different data sources to get at function and palliative need, which is incredibly interesting. They give us rules-based algorithms, which give us an opportunity to talk about the pros and cons of rules-based algorithms, which of course have been, for the most part, the foundation of proactively identifying folks. And then finally, we're going to dive into it, but there are so many interesting issues related to what are we measuring? What is the outcome? What is the lack of consensus? Where do we need to go in order to do a better job of that? So now what I think I will do is do an article summary. And this is intended to be the 30,000-foot view, highlighting enough of the issues, sort of educating everyone on this meeting about them, but doing my best not to impart my opinion, because the second half of this is, of course, the discussion section where your questions will be answered, where we can introduce some of the questions that we sort of pre-canned before this conversation began. 30,000-foot overview of the study. This is in a nutshell what the authors did. Number one, they acknowledge identification of the right people is important. Number two, they said it's really hard to do that if we don't have agreement as to what the conceptual definition, the clinical definition of right people really is. Number three, the authors created and applied 6 rules-based algorithms and applied it to a Medicare population. Finally, they evaluated each of the algorithms using a framework that importantly measures more than just mortality within 1 year. That's your 30,000. Now we'll dive a little bit deeper into the issues that they uncover in their writing. First, this made me fall in love with this study right from the start. They make perfectly clear that their perspective is one of people operating within this new world of value-based care. They said these issues have been here for some time, but we are thinking about these issues, finding the right people in light of these new alternative payment models. And so while their methods may not be perfect for every aspect of palliative care, I do appreciate the fact, and I said I wouldn't inject my own opinion, but I did twice in the first slide, I do appreciate the fact that they ground their perspective in this new model of value-based care because it matters so much to the design, execution, and success of these programs. Then they proceed to say, look, we're hampered by the fact that there is no gold standard. If we as humans can't agree as to who we think the right people are, how can we develop and evaluate algorithms that attempt to do that? And from a science standpoint, if you don't have a gold standard, there is no benchmark, then you can't come out with the next best algorithm. You can't advance the field because it's a moving target as to what best means. So what they do then in response to these challenges is first they do a literature review and they gather all of the conceptual definitions that exist within the literature, and then they assemble a panel of experts. And together they create this conceptual definition that they put forth in the paper. And they say, serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. I appreciate the fact that they further say that the very specific reason they're doing this is conceptually defining serious illness. Their purpose is to identify a population of patients and caregivers who need primary or specialty palliative care services. So that is their foundation for then attempting to turn that into something that could be quantified, something that we could use the data to find the right people for. Next issue in this study is the data that they used. And I thought this was very interesting. Researchers can access Medicare fee-for-service data, and they can access some 35+ million patients worth of de-identified data to conduct these types of studies with. But what the authors did here is they took of the 35 million patients, they reduced it down to the patients within that study that also were part of the National Health and Aging Trends Study, and were also part of the National Study for Caregiving. And what that allowed them to do is to identify folks for whom they had both claims data, which is basically transactional data that describes diagnosis and procedures. It has the cost of care, very valuable for doing this kind of work. But also these two other studies give them, because of the surveys conducted as part of them, they give them insight, they give them data to quantify palliative need and function or activity of daily living data. So that's really smart. They acknowledge right from the start that there's more to it than just cost or just mortality, and where can we find data sets that would allow us to go a step further and measure function and palliative need. And what they're left with in doing this is 7,609 patients that had claims, were still in the community, they had some functional data, they had some ADL data. So that is their data foundation for then mapping that conceptual definition to an operational definition or algorithms that could then be used to find the right people. And here they are, right? These are the 6 algorithms that they used. So we call these rules-based algorithms, and I think that description is pretty self-explanatory. You basically have a group of experts that sit down and say, well, look, we have a conceptual definition of who we think matters clinically. Now, how do we use the data that we have, and we're always limited by the data that we have, to do the best possible job of finding the people that we think meet that criteria? And when you use a rules-based algorithm, you can sort of think of it as a funnel where you start with more people with the first rule that you create, and then you work your way down by adding more criteria that then exclude more people until you're left at the sort of bottom of that sort of funnel with the people that you think are the best possible match for your conceptual definition. And you can see here that the authors used a combination of a number of chronic conditions, whether or not people have been hospitalized within a certain amount of time. They took serious medical condition from a study conducted by Dartmouth. I think the Dartmouth Health Atlas has a list of conditions that they deem to be serious medical conditions. And of course, Amy can correct me on that if I know that Amy's done work in trying to refine and improve that list. But the bottom line is they used a series of rules in order to try to go from more people to the right people. I want to, because this is about sort of helping everyone have a common understanding of the algorithms that are available to us, I did want to talk just a bit about rules-based algorithms. So there's machine learning algorithms, statistical algorithms, rules-based algorithms. This study uses rules-based algorithms, so let's talk about that for just a minute. In effect, a rules-based algorithm is Boolean logic. It's a series of sort of if, and, then statements that we can program in a computer, whether you're doing it in SAS or SPSS or a SQL query. You're basically taking all of the data and you're turning that into code that allows you to say, if the patient has this condition and the patient has been hospitalized, then I think this is the right patient. So the pros of a rules-based algorithm is that they're really easy to understand. I mean, this is English, right? It's interpretable human language, it's narrative, so it makes sense. We can trust it as a result of that. Experts can create these types of rules. The cons are, of course, humans trying to comprehensively create the list of data elements of all of the millions of data points that we have are never really comprehensive in all of the combinations that find the right people. And because it's a rule, the very nature of a rule means that it's hit or miss. You're either in or you're out. And when you write a rule and you create the people that are in, a rules-based algorithm doesn't really set itself up to then say, okay, so of the 600 people that are in, how do I rank order them? Because a rules-based algorithm either says you're in or you're out, as opposed to some statistical or machine learning-based algorithms that allow us to assign a likelihood per patient. So that's a quick sort of detour just to make sure that we're all using common language, a little education around rules-based versus other types of approaches. So then the evaluation is introduced. And this is where the authors try to move us away from simply counting mortality. They map their conceptual definition to the following categories. They say that we think right translates to these outcomes, and we want to see how many of them have these types of outcomes. In effect, they're translating what they think matters into the numbers. And what they think matters is understanding your total cost, whether or not you've been in the hospital in a year, whether or not someone died within a year. And then they look at the percentage of the group that had, are you in the top 10% of cost? They map the data from the surveys into palliative need. And also they map the ADL data. They basically look for whether or not you have a number of ADL impairments from one of the other studies that was included in this. And in this way, they say, we believe that the way to measure whether or not they are the right people is based on a combination of cost, utilization, mortality, and palliative need. And I think this is a really solid advance away from simply considering mortality as the end-all be-all. Now, we're not going to attempt to interpret this whole table, but the authors say that the measures that matter most in figuring out whether or not people meet these criteria is basically sensitivity, specificity, and C-statistic, or area under ROC. They're the same measure. And along the left side of the table, you can see each of those categories: top 10% of spending, hospitalization, death, indications of need. And along the top, the column headers, you can see the different algorithms that they tested. And it's really combinations of rules. And then across, they show you their results in evaluating each of these different metrics by sensitivity, specificity, C-statistic. I just want to talk for a minute about each of these measures, because how you interpret them, there's one way, they mean one thing, but I think the ability to map them to the problem you're trying to solve, to move from research to practice, is incredibly important. So I want to take a quick minute on this. Sensitivity, and I'll use mortality as an example, but again, they evaluate across each of these measures. Sensitivity, if you translate that to just a sentence, it's basically testing of everyone that died within a year, how many of them did my algorithm pull back? So when I cast that net, how many of them did I actually catch? And a sensitivity of 0.22, which is the sensitivity of this particular algorithm, basically means that if everyone died in the 7,609 patients that were in their eligible population, 22% of them were pulled back by this particular algorithm. And that means that 78% of the deaths occurring within the population were not returned based on that algorithm. So I think that's important, that everyone is able to sort of understand how to think about sensitivity. And we'll talk about the pros and cons of that as part of the discussion. The next is specificity. Now, specificity is a really interesting statistic to include in identification algorithms. There is a long tradition of including specificity in clinical studies, but really its roots are in evaluating the performance of a diagnostic test. Actually, to be honest, its roots are in military applications to determine whether or not a blip on a radar is an enemy submarine. However, we have adopted that. We apply it to diagnostic tests. You'll hear a lot about specificity as part of what's going on right now in the evaluation of COVID diagnostics. And oftentimes we apply it to these types of algorithms. But I want to be clear as to what it's measuring. It measures the ability of an algorithm to identify those that don't need help or that don't die. So it's basically saying, how good am I at ignoring all of the people that don't need my help? That is very different than measuring how good am I at finding the people that need my help. So a specificity of 0.96 basically says 96% of the people that I left out in the population, I did not pull them back, did not die. In this study, what that means is the algorithm, this particular algorithm, did not return 7,000, it did not return 7,333 people. It left them behind. And of them, 293 died. So very few people in the general population died. C-statistic is the combination of the two. It's sensitivity and specificity. One more comment on specificity. Because it's measuring of all the people that didn't need my help, how many did I safely ignore? You can be pretty deceptive in using specificity to measure how good an algorithm is. Because for populations where we're looking, a big population that's looking for sort of needle in a haystack, like sort of small end results, you can sort of make an algorithm look really good by having millions of people that did not need help, that didn't get returned. Again, that's different than using a statistic that says, if I give you a list of people, how many of them are the right people? That statistic is positive predictive value, or precision is another word for it. So I just want to be clear on that, because if we're looking for statistics that help us measure how many are the right people, we really want to look for positive predictive value. And this means of those we predicted would die, or be hospitalized, or be in the top 10%, how many actually did? And that is the statistic that most closely mirrors what happens in a clinical situation where you're handing somebody a list of people that you think need help. Here's the good news. Although the paper does not call it out as positive predictive value, if you look at this table, each of these tables, and they present the 6 of them to report the results of their algorithm, they actually are returning the positive predictive value. And I think that's really interesting, because the authors lament just a bit that maybe the performance of the algorithm wasn't as good as they had hoped. But I want to draw your attention to the fact that the positive predictive value of some of these algorithms, depending on what they're measuring, is pretty good. So in this example, you can see, and you can work backwards off the math in the paper, this algorithm returned 276 people. Of those people, 90% of them actually had palliative need. So the algorithm does do a really nice job to find palliative need based on claims data alone. So I think, again, that's sort of a really valuable contribution of this paper, and it's very provocative as to what measures should we really be focusing on depending on what we're trying to accomplish in the clinic. So the results and the conclusion presented by the authors is, number one, they gave us a multifaceted conceptual definition, and they mapped it to an operational definition, those outcomes that we just talked about. They do conclude, correctly so, that all of their algorithms had low sensitivity but high specificity. But again, I question the value of specificity for finding the right people. I do think it's very important to understand how many do we leave behind, which is sensitivity. They conclude that standard administrative data are inadequate to identify this population. And then I think they do a great job of listing 6, 7, 8 really rich areas for future research priority. And I would highly recommend folks read through those and think critically about how many of them they should get behind, because I don't know how many are currently on, but what an impressive number of people, list of individuals and organizations represented here that really represent the future directions for this really important area of research. So I'd recommend you take a look at that. So my 3 cents, and when I translated them from Google Drive to PowerPoint, they turned into 3 number 1s apparently, but my 3 cents are, what an incredibly valuable framework for measuring the outcomes. And I think this is a foundation that we can build upon. I'd like to imagine a future state where everyone who's trying to find the right people is getting closer to a standard quantifiable way of measuring how right or wrong they are for specific programs. Number 2, although the authors claim that standard administrative data isn't adequate for doing this kind of work, I think they don't give themselves enough credit for having discovered the fact that this rather basic algorithm for finding the right people returned 90% of people that actually had palliative need, at least by their definition. So I think there is more potential there than they give themselves credit for. In addition, if you read the data science literature, others have shown that they can do a really nice job using claims alone to predict utilization, cost, and death. So I really do think we have a pretty solid foundation. I think there's a lot of useful work to be done here that we've only begun to scratch the surface on. And finally, I really do think we as a field should buck tradition and maybe call into question whether or not specificity and area under ROC are the right metrics for this kind of work, or at least include and acknowledge the importance of positive predictive value. And then there are measures that combine sensitivity and positive predictive value. It's called an F measure, F1 measure, harmonic mean. So I think there's a great opportunity for data science and palliative care to come together to use, you know, the measures of the different communities to come together. Because again, mostly what we're doing here is trying to find, of the people I return, how many of them are the right people, and those are the right measures for that job. So credit goes to the authors. Those are some pretty good positive predictive values for identifying palliative need, which has largely been ignored in a lot of the more automated algorithm ways to find the right people. Okay, that was a really pretty fast run through some really meaty issues, but you don't want to use a journal club to really recap what hopefully most folks did get a chance to read. I would like to open the discussion by asking Amy, and she knows that I have a thick skin. Amy, what did I miss in running through that study at that speed that you think is important to highlight and bring to everyone's attention?
So I thought that was a fabulous summary. And first of all, just thank you, Len, for bringing us all together. I am so thrilled to be part of the Rockstar panel and to have you getting this conversation rolling, and to know that there's more than 100 brilliant people out there listening who are going to help crack this nut with us. So first of all, just thank you. And that's really exciting. This partly responds to one of the questions that's already shown up from our audience, but I think one of the important things to come back to when thinking about this paper is the ability to identify this right group of people, because we have a line of services that we are hoping they will benefit from. So we didn't spend a lot of time talking about what palliative care is and what palliative care offers. But in a very brief way, it's important, I think, for our audience, and especially the data scientists, to understand that palliative care brings a complementary level of support to a patient and their family when they're struggling with serious illness. It focuses on symptom management, complex decision-making, ways to prioritize personal values and goals that are a key part of an individual person's life, and support their caregiver during that time as well. And as you all know, especially the data scientists among us, those are not the things that are in our EMRs. They are not the things that are in our claims. And that's really the crux of the problem. We have this incredibly powerful service that targets very specific things, and we have almost no data in our day-to-day world that measures those things accurately, consistently across populations, so that we can very efficiently get the right service to the right person at the right time in the right place. So I'm excited to sort of dive in more to this, to think about where the potential solutions lie, because as you point out, the rules-based algorithms, you know, one of the reasons I thought that was an important approach is because, you know, a clinician can say, my person hits these criteria, I'm going to enroll them in my program. A practice can say, these populations are eligible. It doesn't require that heavy lift of background analytics on a whole lot of data points. And yet that process, whether it's AI or machine learning or all sorts of things that we can bring to bear with all of the data we have available, could probably help us do better to make that bridge. So I think to get the conversation launched and the discussion among the group, I think one of the pieces I wanted to highlight is that that our ability to measure function in our available data is really lacking. And I think that's an area we should think about from a data science realm. How can we proxy it? How can we build better measures into our natural data collection process in our clinical work? And I think having raised that issue, I think I'm going to pause and see what others have to say.
This is Dana. Yeah, Amy, such a great point. And again, Len, thanks for pulling us all together to really begin this amazing discussion. Pulling surrogates for frailty are so important because again, as we've just discussed here, it's important to get away from just looking at mortality models, but rather looking for how do we find suffering? How do we find people that can benefit from a high intensity care model, delivering care at home? And what kind of surrogate markers for frailty? If we can't get an ADL assessment, can we look for things like decubitus, bed sore? Can we look for durable medical equipment orders, like the ordering of a walker, a wheelchair, home oxygen with some other diseases? And as we start to see some of that, those surrogate markers for frailty or clinical decline, how do we really weight those heavily too to show the really severe need and progression to homeboundness of a high need population who could benefit from this kind of care, even if they might not be dying?
Yeah, just to piggyback on that, I totally agree, Amy. As a practicing palliative care nurse practitioner, you know, as clinicians, we know how important understanding function is because we see the impact on patients and families every day. And I think what's interesting about this study, where what you included in terms of what can we get at from claims by way of ADLs, because there's not a lot of clinical data available, you know, home health, SNF, DME claims actually did a fairly good job. I mean, 59 to 67% had ADL impairment with just those claims, without ADL claims actually. And then it goes up to 73 to 78% with those additions of home health, SNF, and ADL claims. So that, to me, that's actually a really good news, because in the absence of clinical data, we can use claims data. And then I think the question becomes, from a data science perspective, how much lift does that give us, you know, over time in different data sets? You know, we have some evidence here from a Medicare fee-for-service population. How much lift does that type of ADL data, the data that we have access to? We want, you know, access to better data sets for sure. Like, we should set our sights on that. What can we do with what we have, and where, you know, how can we see how that plays out across different populations?
You know, one of the things that's challenging is, in those of us who are serving in these communities, especially in a fee-for-service model, we don't have access to that data real time. And one of the things I think every palliative care program uses is a palliative performance scale. And so I know within our CMMI project, in which we enrolled 6,000 patients, over 85% had a palliative performance scale of under 70% or under. And when many of those who are, or I guess all of you who were on our alternative payment model task force, the PAXI model, the patient and caregiver support for serious illness care, we actually used PPS for the criteria. So if you were a cancer patient with a PPS of 70% or end organ failure with 60%, you made it in that eligibility. And I wonder what you all think about that. I'd love to hear some more discussion around that. It's hard because you can't pull a PPS out of a claims data anywhere, but at least it's something that palliative care people can address and assess with a patient that's being referred in.
I think it's a great point, Janet. I think it's an easy tool to use. I think there's some efforts we could make by way of standardization. And I know there are people nationally have been working on, you know, the measures that matter and standardization. And we have sort of the convergence of the 4 registries, you know, coming together this month, I believe, or next month, maybe they're launching. So, you know, I think having some agreement among all of us in the field about what we're going to measure makes a lot of sense. And then I think what would be really cool is, can we move that upstream to primary palliative care? Because it's not a difficult tool to implement. And then we would have more data clinically available for funneling people into palliative care programs. Because I think that's also one of the main challenges, is we often don't get that data until people are in. And so how can we get it farther upstream? That's a great point.
Jana, what were your findings in terms of the ability for PPS to discriminate? I'm just wondering, you know, if the bulk of the patients are kind of in the middle, does it help you if you know, I don't know what your data show, but if the bulk are in that really average big chunk range, does it discriminate for you?
Well, actually, I was pretty surprised. We had a 64.5% mortality rate, so super high. And we, you know, the majority of our patients had a PPS really in that 50% or less. So we were getting a lot of referrals of really sick patients. So that's a good point. But you can actually see some discrimination between 50 to 70% for sure.
I think this conversation ties in well with what it looks like is the cue Len's giving me to talk about this next issue.
Not a cue. It's not a cue. I just wanted to make sure I could still advance. I'm getting texts from Sarah that say, stop moving your mouse. So
well, I think it's a great way to build on what was just said by my colleagues here, and also to tie in a question about the sensitivity issue. So as you choose an algorithm, you find a population, and then you might, you know, find a more and more narrow population with potentially higher needs, depending on your criterion. And that to me speaks to the fact that we do need different algorithms, and we need different denominators. You know, there has been this discussion around the quest for the perfect denominator for our field, and yet simultaneously our field of palliative care has developed many different service program types. And so whether you have a set of criteria that you want to use for a trigger of palliative care involvement in your intensive care units, that's a different set than the trigger you're going to use to launch an advanced care planning and care management program in your ACO, right? So any of those could be considered sort of under the broad umbrella of palliative care services. If you want to do a home-based concordant palliative care program, you are going to be limited by your workforce, and you're going to have to think about, who am I finding? How much does my service cost? What's the return on that investment in terms of both the quality and cost avoidance for other things that may be happening? So I think we should set our sights on multiple definitions and multiple algorithms to find people for the right service.
Amy, so you did the lit review and you formed a team of experts to come up with a conceptual definition. Was there controversy surrounding that? And then the follow-up question is, did that same panel of experts participate in the operational definition? And how much consensus was there in translating the conceptual to those outcomes that you put forward as being the outcomes of import?
So, I mean, whenever you take on an important topic and get a group of really smart, passionate people in the room to make a decision, there's always controversy. So I'll just say yes. But so it was actually a part of the work, and this paper stemmed from a broad sort of program grant from the Moore Foundation to do a whole line of palliative care focused work with a particular kind of pragmatic eye to the policy realm. And it was amidst the time that CMMI is considering new payment models and so forth. So we had at our disposal kind of the cream of the crop minds in the palliative care field, including the group you can see in the panel here, and got a whole lot of input and people with a range of different perspectives that informed the definition from multiple angles. I think one of the maybe stickier spots, and it translates into the need for different denominators, is issues around mortality. Hospice, which is a subset of palliative care, is very specifically targeting a group with a limited prognosis. The reason we have risk of mortality in the conceptual frame is that we all know that we encounter and serve patients who are coping with a very high risk situation, for example, a bone marrow transplant or a solid organ transplant, or something that they hopefully could have even achieved cure from. And yet they may be truly suffering, have a ton of symptoms, have an overly strained caregiver, and need our services significantly for a period of time. So the conceptual frame is really meant to have that flexibility.
And let me just ask, because I can't click through the questions here, but are Martha or Janet or Dana, are you seeing questions that are being submitted that would suggest we need to help people understand certain aspects of what you did? Or I would encourage folks, if that's the case, and there are questions, what an opportunity to ask the study's author, why did you make decision A versus decision B? So I would encourage folks, if you're reading that study and thinking about those decisions, send them right into the Q&A and we'll get at them. We'll try
I think
to.
a couple of the questions do focus on palliative care need and in particular caregiver strain, which is part of what's in the definition. So for our analytic approach, the immediate challenge became the fact that those things aren't measured.
Yeah.
They're just not measured. So we use the survey data to kind of do our best to proxy our way up to something kind of close, but they fall short.
And we didn't talk about how you did that. I don't know if you think additional color is warranted or folks should read it in the paper, but it's a mapping exercise. What data is available versus, clinical expertise to say, we think this counts as a functional need, a palliative need, et cetera.
And there's a question here from Anita, which is very good. And how do you envision different steps or ways of using an algorithm that a health plan might provide to a provider group doing palliative care? So the health plan or some other entity identifies this high-risk roster, and how might that be used? And I'm going to take a crack at that and then hear from the other panelists. But I have gotten those lists from various health plans for our home palliative care program. And sometimes these lists are just simply their high-cost patients. They're not really people with a lot of suffering and impactability. And so what Amy's done in her paper here is identified people not only with serious illness, but some evidence of care fragmentation, which is also what CMMI is going to be testing in the seriously ill population portion of the primary care first model. So looking for care fragmentation through hospital admissions or patients bouncing around a lot to different providers with different taxpayer ID numbers. So there's no captain of their ship. So looking for opportunity to help people who are suffering, who also have serious illness. So a list is great if it's given to a group of folks delivering palliative care services, but the population has to have impactability with the clinical model. If it's a Medicaid population where there's a lot of substance abuse and addiction, a medical model isn't going to work. And we learned that from some of the work published in the Camden Coalition. So the program has to be well known for the roster or algorithm of the patients we're trying to identify, and they have to match.
Yeah, that's a great point, Dana. I think one of the challenges as we deal with payers is because most of the data shows that that you save the most money in the last 3 months of life. The payers that I talk to are more interested in finding algorithms that identify those patients. And so I see the future kind of being this blended program where you'll have fee-for-service and alternative payment models.
And I do think once you receive that list, physician, these are people who potentially would benefit from palliative support, there needs to be a secondary way to evaluate, which would, I think, require analytics on the EMR that might dive into things like the PPS. We use the PPS to determine where a patient would best be seen. So a person with a PPS of 70 or greater actually could be seen in an ambulatory setting. And a person with a PPS of 70 or less should be evaluated for home-based services so that their energy conservation, et cetera, is really maximized. So it also helped to understand where you would best serve that person, not just who you should serve.
You know, in our experience working with palliative care organizations that are partnering with health plans for the first time in these ways, I think the one thing that I have learned is it can be dangerous if the list is handed as opposed to a conversation around what is this program designed to do, what are our key performance indicators and measures of ultimate success. And I think that palliative care organizations that are equipped to have that conversation and to use the data to position them to find the right people are in a different position than those that are handed a list and then told to perform. And we've seen that sort of play out in both directions.
Absolutely. And there's also the patient who doesn't end up on the list, but the physician, because, or the team, because they've met them in circumstances, identifies them to be at risk. They just haven't experienced it yet. And a lot of the times we're waiting for people to suffer in order to give them the support. Ideally, we want to find ways to find these people before they begin to utilize, before they begin to put in claims, so that we can maximize their quality of life and have a plan and kind of redirect. But right now it's a reactive model if it's based on claims.
After the first hospitalization, right? You have to be hospitalized or else you don't qualify. So, you know, if you can prevent that hospitalization, that's really where you want to, that's where you want to enter. And that's what you're saying, Martha. I so agree.
But that's a really meaty issue, and maybe one we should take on in a future club. There's a big difference between finding people that are at the height of acuity versus, you know, skating to where the puck will be. And there's incredible challenges in both doing that, but also establishing a culture in which that is recognized as being important. Because again, we're working against a culture of, here is your list, mostly identified by actuaries that are finding the oldest, sickest, most in need people, which I think is, you know, are not always the people most likely to benefit.
I love you brought up that issue, Martha, because I think, like, just to have a example, you can imagine the older, frail heart failure patient, and all that shows up in their claims is heart failure, which clinically is totally meaningless, right? And if you know that person, you might see that their functional status is declining. You might see that their shortness of breath is increasing. That's the right time that that person needs our services and would benefit from them. But our models require that person to get so bad that they come into the emergency room and have an admission, or maybe even two, and then we decide to help. So I think we got to crack that problem too.
And don't read this as a cue. I'm just going to advance the slides a bit to make sure that we are hitting the issues we said may matter.
One of the questions that was brought up in the chat is, can we use these algorithms to identify people for goal concordant care conversations? And I think absolutely. These are the people we want to be finding out. Do you want to go to the hospital? And you know, can we look at more of a comfort plan of approach? So I think that's a great point.
And Len, as a segue into this next question here, focusing on problems with mortality models, we have a question from Anonymous who says, how far upstream do we want to identify patients? And I think, you know, this is sort of the holy grail here. You know, you want to help people who need to be helped. Part of it depends on what is your program good at, who's paying, how is the program's success going to be measured? If you're only measured on people who die and do they die less expensively than a control group, then you're really going to focus on mortality. But if you're really accountable for a population, you might go up higher. Instead of just the 2.8 or 3% of the sickest, you might actually go more upstream to serve the sickest 5 to 10%. So somewhere maybe in that range of 2.5 to 10%, but again, it really depends on who's paying and how your outcomes are going to be measured. It's a great question.
I think it was interesting that in the CIP model, they use an HCC score of 3, because that's a pretty sick individual that hits that score. So,
yes, and I think the average, Janet, mortality of that population is about 12%. It's not, as Amy's work here, showing that 25% in 1 year. So the CIP model, on average, looks like it's a much lower mortality group.
Janet, I think we did touch, and again, firing questions that are coming. If you feel like we hit this one already, I'll hop to the next one that we had talked about.
I think we hit it.
All right. So Dana had what I think is a hugely important point in some of our sort of pre-session conversation. Dana, I'd love for you to dig into this one a bit.
Yeah, so, you know, it's really important as you're looking at your algorithm for your program that you take into account maybe 2 key factors here. You know, one is, and this will come up with the CMMI seriously ill population model, where they're going to have the government or folks from CMMI or some CMS entity will be cold calling the patients that are identified in the algorithm. At least that's how it's laid out now. That might change. And this is set to launch in April of 2021. But the two things I always think about with algorithms are enrollment or engagement, people that will say yes to getting enrolled in your program. And then the second thing is, how big do you want your program? You know, how many people should you serve? So on the enrollment side, what I loved is when the enrollment, when we had a whole bunch of people say no to us, I was like, oh my goodness, why should that be? We have this great program. How could they say no? Well, that happens for two reasons. They're not the right patient population. They're too healthy or something else. Or the call didn't go as well as you would have hoped. It was a trust issue. Maybe the caller didn't do well. And you can get obsessed with the no's to try learn more about that. Is it a problem in your algorithm? The guy that you called is out driving Uber. He's all better now. He had a one-time catastrophic issue that's now better, and the algorithm enrolled him and he's not at all appropriate. Or there was something maybe with trust and that kind of thing that could be worked on. Just the second thing I'll say quickly is, how many people do you want to serve? How many people do you have working on your team? If you are only going to have about 80, 85 people per FTE, then you might want to really narrow the funnel so that you really are finding the very sickest people with the most suffering. If you have excess staff, you can widen the funnel.
So I just want to make one point on this, and this is a data science thing. A rules-based algorithm brings back a number of people, and it doesn't rank order them. One of the reasons, it's all about what tools do you have in your toolkit and doing this kind of work. One of the reasons to consider an algorithm that assigns a score of some sort, either a probability or some other metric, to the individual is if you know you have a program that can only make 50 outreaches a week or can only handle 100 people being enrolled, then you don't want to evaluate your identification algorithm's performance based on its performance for 10,000 people. You really want to be able to say, I can only take 50 a week, 50 a month. How good is this algorithm at finding the right 50, the positive predictive value, on a week by week or month by month basis? And suddenly, even the way you measure changes based on mapping it to the way this is going to work in the real world in your clinic. And that's often lost when we talk to organizations and they say, how good is an algorithm? And we say, well, for how many people? Because if I'm trying to make a prediction for 100,000 people, that's very different than returning back to you the 10 people today that are in your home health program that should probably have a goals of care conversation for hospice. Very different ways of measuring the performance of those two things based on, again, as you said earlier, what are you trying to do? What are the goals? What are the success measures here?
And I think what's going through my mind listening to Dana and Len is this idea of what we talk about a lot, which is pairing the data science with the clinical judgment, and that there's a dance to that. And a lot of what you brought up, Dana, around, did the call not go well when we called to enroll people? It's kind of like, what conversation are we having with people and for what reason? And whether we're enrolling them in a program or calling them to have a primary palliative care conversation or to stimulate a goals of care conversation really changes the kind of script that the clinician needs to use in terms of engaging with that patient. So sometimes we hear, well, these people are on the list, but they're not dying, or how do we move upstream, but how does that change the conversation? So it's really interesting, even as clinicians, we get used to sort of what we're seeing on the list. And we're like, well, why does this person even need palliative care when we're trying to move farther upstream? And those can be challenging to sort of sort through. So I think having not sort of automatically reacting to the algorithm, what the algorithm says, but having these kinds of discussions among teams around, how do we think this person in front of us could benefit from palliative care, and, adjusting the conversation to that need.
And equally important, having a good exit strategy or discharge strategy when we get people where they need to be. I think that's one of the issues I see with a lot of programs, is not knowing when it's time to back out because you only have so many resources. And you've got to use those resources on the right people. So further upstream, the healthier patients you get, it can be really burdensome for the team.
The other thing too, I'll say, you know, data freshness matters. And so a hospital admission that was unplanned last month is much more important than an admission that happened 11 months ago and there hasn't been one since. And so when you call that 85-year-old and say, you know, Mrs. Cohen, this is Dr. Dana, we've got a nurse in your area tomorrow. She's going to check in on you because we're worried about you. She's much more likely to say yes if she was just really tortured in the hospital in ER last month versus almost a year ago and she's been really kind of doing okay since then. So, you know, data freshness really matters.
And data freshness is a challenge when you're using claims data, as we know, right? It's part of that triangle. Will I have this data in my environment? And if I do have it, how frequently will it be updated is important.
Yeah.
I did not put this slide up to end it, but I did want to remind folks that this is being recorded. We will post it. We will go through the questions and answers that we've received. I think we've already touched upon really interesting future, like what happens after the algorithm. It's just a suggestion. What do you do next? The ethical issues of identifying people based on mortality or other palliative considerations is loaded with interesting discussion points. And I think an interesting paper just came out of UCSF. It was a blog post in Health Affairs. I know that Dr. Steve Pantelat and his team authored it. And I think it, you know, it begins to push on the ethical concerns, and that may be something we talk about. Measurement of whether or not a program worked is a hugely important issue that would benefit from palliative care and data science coming together and talking. So if we have time for one more quick question, we could take it, but as people drop off, I just want to say this was hugely intended by some really impressive people. I'm so grateful that the issues of analytics in palliative care are coming to the forefront, are of interest to these, you know, really influential people at phenomenal organizations. And of course, I know it has much to do with the incredible talent, dedication, integrity of the people that were kind enough to join in this conversation and organize it. Of course, Dana, Martha, Janet, Amy, and Caitlin. I just think it's fantastic that we got the ball rolling on this. We'll see, because we're going to collect data. The feedback could be never do this again, but I think so far so good. I don't know if we have time for one more, or we should probably hang up, but maybe what I'll do now is just say thanks, and you can keep sending us questions and we'll do our best to gather them up. Thank you to the attendees, and thank you to our wonderful organizers. It's an honor to be able to work on these issues with all of you.
Thank you, Len. Thank you for having us.
Bye. Thank you.
Thanks,
Okay.
Glenn. Appreciate it.
Yep. Bye, everyone.